Alright, so our beta-adrenergic blockers or beta blockers. Something that is consistent in the naming of these is that they end with an OLOL. So sometimes they're here for the lols, right? So propranolol, atenolol, that kind of stuff. So what are your beta blockers used for? Well, they're going to be blocking those beta adrenergic receptors. So you see a lot of this used working on the heart. Propranolol is a non-selective beta blocker, so it is going to block both beta 1s and 2s. Being a non-selective, it's really good at treating angina, dysrhythmias, hypertension, and migraines. The migraines part is kind of like one of these side effects that was figured out later. Like when propranolol was first made, it was like, this is an anti-angina drug. You're going to take it, it's a beta blocker, it's going to decrease heart pain with activity. So angina is when people are moving and doing stuff like climbing the stairs, then they get chest pain. That's angina. The way propranolol works is when it blocks the beta adrenergic receptors, it decreases the overall effort the heart has to produce, which decreases the O2 consumption of the heart. And what happens is, with what causes the pain is the heart muscle is working really hard to pump, and it starts running out of oxygen because of some coronary artery, something or another. Whatever's happening is the heart muscle is not getting enough oxygen, lactic acid is building up, and the heart does a really crappy job of clearing lactic acid, and you feel that as pain. But the migraines one was just kind of like a side effect. It was like, oh yeah, also if you take propranolol, people don't get migraines. It will, though, put you on your butt. So some side effects for it is hypotension, so decreased blood pressure, restless sleep. You might feel really tired after you sleep, so it'll make you kind of sleepy, but then when you sleep, you wake up and you are still sleepy. Another thing is hypoglycemia, especially in diabetics. It works with the liver, or it influences liver metabolism, and people who are on insulin can bring that down, and then the liver's not able to bring the blood sugar back up. So it has a lot of side effects. Clinical concerns: if somebody has asthma or first-degree heart block, they shouldn't take this. Typically, propranolol is heavily metabolized in the first pass of the liver. So the dose that you take gets cut down pretty quickly by the liver when you take it. Doing that, it takes enzymes to process the propranolol, right? And so it's those enzymes that help with hypoglycemia. And some other things you see is serum lipid levels, so cholesterol levels can go up if people are on propranolol. It's also lipid soluble, and so being lipid soluble, propranolol is able to cross the blood-brain barrier. So it can cross the blood-brain barrier and actually create sedative effects in the central nervous system, because you are blocking adrenergic receptors, right? And so you'll see sedation and sometimes depression linked with propranolol. Another one, atenolol, if you look up here, atenolol is also a beta blocker, but this one's water soluble, it's not lipid soluble, and so you don't see it working in the central nervous system like propranolol. So people who need beta blockers but aren't a big fan of sedation and restless sleep can take atenolol. Another one is low pressor. This one is B1 selective. So propranolol is just any betas. That's why you see the bronchospasms in there. But with Lopressor being a B1 cardioselective blocker or antagonist, it's going to have less side effects, but still can have a lot. We see it used in mild to moderate hypertension, so mild to moderate high blood pressure and angina. Works kind of the same way with decreasing the load on the heart. It means it needs less oxygen. It means it's not going to hurt when you're being active. Clinical concerns, again, heart blocks. If someone has bradycardia, they shouldn't be taking this. If your heart rate is low, you do not want to take something that is going to make your heart rate even lower. Bad idea, right? And people who've had heart failures, it's a bad idea to take this. All right. This group is going to be the cholinergic that we're going to be focusing on. Pretty much all your cholinergic drugs are going to be non-selective. So they'll bind both nicotinic and muscarinic receptors. Here's just kind of how acetylcholine works, where you have it released and then it gets broken down by acetylcholine esterase into the choline and the acetate, and then taken back up to be used again, either at your muscles or in your autonomic nervous system, in your parasympathetic autonomic nervous system. This would be somatic motor. So across both. And so some of the things when we're talking about muscle relaxers, some of them do block cholinergic receptors, which we'll talk about. Again, they can be direct, so working directly with that receptor, or they can be indirect by inhibiting acetylcholine esterase. So if you stop the enzyme that breaks it down, it means it's going to be more of it out there, which means it can bind the receptor more often and cause a bigger change in that cell. So the major uses of this is you see it stimulating the bladder, increasing GI tone, constricting your pupils, increasing mucus, especially like in the nose and other areas. The first one that we're going to talk about is urocholine or bithanochol. This one, again, is going to be binding your muscarinic receptors. So we're in the parasympathetic mimics. So they're all going to be binding muscarinic receptors. And it's used with urinary retention. Side effects, nausea, vomiting, increased salivation, increased sweating. Again, stimulating those muscarinic receptors is going to increase salivation. Clinical concerns, take it on an empty stomach. Do not give it intramuscular or IV. This could cause the circulatory system to collapse. You can get hypotension, shock, cardiac arrest. Like, take it as a pill on an empty stomach. Pilocarpine or Pilocar is another one. For this one, it's used in ophthalmics, so eye drops, and it's direct acting on the muscarinic, and it causes constriction of the pupil. Side effects is sweating, nausea, and runny nose. Something that you see with pretty much all eye drops is runny nose, because you have your lacrimal duct right here, and any liquid that you put in your eye goes and drains down that lacrimal duct that leads to your nose. And so any ophthalmic solution is going to cause a runny nose. This one more so because it is also a muscarinic binder. Right, it's a muscarinic agonist. Do not use if you have a detached retina, high or low blood pressure. Different ones cause different concerns, or glaucoma. And then we have our anti-choline esterases. So these are going to be things that break down acetylcholine esterase. And so they're going to keep acetylcholine in the gaps longer. And so it can increase. So these are all like muscarinic agonists, but they can also be nicotinic agonists, right? Neostigmine is one that we'll talk about again, too. And it's used to treat myasthenia gravis. Myasthenia gravis is an autoimmune disease where it attacks the neuromuscular junction and kind of breaks that down. And so having more acetylcholine there can keep the muscle strong and usable. And so you see neostigmine used in that. Urinary retention, excessive skeletal muscle blockers. So when we talk about non-depolarizing skeletal muscle relaxants, sometimes people can get too much of those. That's a bad thing. Neostigmine can take care of that issue. And so if you mess up, give them another drug. And that's kind of like the whole story of pharmacology. It's like, okay, we do this, great. If something else happens, give them another drug. If this doesn't work, give them another drug. If that doesn't work, give them another drug. And so with neostigmine, it can block or counteract, reverse too much skeletal relaxers. Side effects, again, muscarinic, can give you increased salivation, sweating, nausea, vomiting. Clinical concerns, bowel obstruction. So your muscarinics also increase your GI motility. And so if you take neostigmine, you'll start moving stuff through your intestines a lot quicker. And if there's an obstruction there, it can cause bursting and severe pain. Peritonitis too. So if you have inflammation in the peritoneum, in the membrane that you find around these organs, probably shouldn't be taking it. Another one is Razidine. This one's cool because it's used to treat Alzheimer's. Again, it's an acetylcholine esterase, but it's going to cross the blood-brain barrier and is specific at keeping acetylcholine active or around in the central nervous system. Some side effects is nausea, vomiting, loss of appetite, heartburn, and something that we see in Alzheimer's patients is a lot of them are losing weight either because they forget to eat or they don't want to eat or whatever that reason is. A lot of Alzheimer's patients just kind of waste away, and having a loss of appetite with that's not a great thing. Clinical concerns, again, if somebody has an abnormal EKG, atrioventricular blocks, or ulcers, they should not be taking this. There's a newer drug out there, Cognex, which works better without giving like the loss of appetite. And then there's Namita, which blocks glutamate receptors of the central nervous system, which is kind of like a different way to go about it. Glutamate is a really common excitatory neurotransmitter in the central nervous system. So patients with myasthenia gravis, also people who get exposed to organoinsecticides or people who have been victims in chemical warfare, can get into a cholinergic crisis where they have too much acetylcholine working, right? And we can treat that with praloxidone. And so in a cholinergic crisis, you can treat that with pralidoxine. It reactivates acetylcholine esterase, and so it can break down that. Some signs of cholinergic crisis, the SLUD, more salivation, more lacrimation, so more tears, more urination, more defecation are signs of a cholinergic crisis. Some other anticholinergics getting into also / muscle relaxants would be botulinum toxin, Botox. So what it does is it inhibits acetylcholine release. So it is still an anticholinergic, but this is also affecting skeletal muscle too. And so it can be a skeletal muscle relaxant because it is blocking the release of acetylcholine. Botox is used a lot in cosmetics, where it decreases wrinkles around the eyes, but it also decreases spasms from cerebral palsy, also migraines, especially like running up the back of the neck. Some of those vessels can get constricted from the muscles, and you can relax them with Botox. We'll talk a little bit more about Botox when we get into the skeletal muscle relaxants. Other reasons for anticholinergics are pre-op meds, antispasmodics. What you see with this, like still sticking with the PANS kind of side of stuff, is dry mouth, dry mucous membranes. Again, we'll talk more specifically about different ones of these drugs when we get there, but atropine sulfate is a big one. It inhibits the acetylcholine vagal effects. So our body kind of has a resting parasympathetic activation level, where it's always just kind of doing its thing. Parasympathetic innervates the heart and keeps the heart rate, with the sympathetic kind of in this happy medium, right? Like, what should your pulse rate be? Probably about 70 beats a minute. If you slow down, or if you take away the vagus nerve, which is the major parasympathetic nerve that innervates the heart, you're going to see that heart rate goes up. It's like 120, 140 beats a minute, and atropine can do that. So it increases your heart rate. It's used when people have bradycardia or peptic ulcers. Side effects, again, a lot. Dry mouth's a big one. Blurred vision, urine retention, constipation. Bentyl or dicyclomine is another anticholinergic. This one is going to be blocking the muscarinic receptors, and so this is going to decrease overall GI motility. It's used a lot to treat irritable bowel syndrome. So with irritable bowel, like, stuff is moving through way too quick, and you can slow it down with dicyclomine. Side effects, the opposite of that. So you slow it down and you get constipation. Again, urinary retention and dry mouth. Glycopyrrolate is one used in pre-ops to decrease secretions. So if you're going to be working on something and you don't want a lot of mucus around, you can give them glycopyrrolate. Also, certain GI disorders, it's pretty similar to how dicyclomine works. And then the scopolamine patch. Scopolamine might be something you heard of before. Similar drugs like Dramamine, right? So it's an antihistamine, but it's used for motion sickness. Again, Dramamine's another example of this. And so it's just a patch. You put it on, and it starts to absorb. So it can give you side effects like dry mouth, visual disturbances due to pupil dilation. Also, certain prescriptions cause nausea. Certain prescriptions cause motion sickness. And so sometimes it's like, hey, take this drug. If it makes you sick, here's another drug, right? All right, we're going to pick up with our muscle relaxants in the next section.